I wish I had your graphics. So what I'd like to talk about, I mean, one of the nice things about this kind of speed dating format here is that you get to, see different angles of how different delivery systems are approaching this. And so what I'd like to talk about is in terms of Atrius Health, which is a physician, not hospital-based integrated delivery system in Massachusetts, how we have worked with a VNA in Massachusetts that we acquired 2 or 3 years ago. So this is early in our journey. And I want to talk more about, less about necessarily the models of home delivery, although you'll see that's integrated, but really about how we've thought about integrating better with our VNA partner, which is now a wholly owned subsidiary, to be able to prepare ourselves to take care of our Medicare Advantage, our Pioneer patients, and ultimately our commercial patients. We are a Pioneer ACO. We have around 35,000 patients, and we have around 25,000 Medicare Advantage patients. That's $500 million worth of risk. And so we acquired them very strategically and specifically to be able to manage this population and fully cognizant of the fact of what we've seen today in terms of where the demographics are going. So Atreus Health, as I said, is an alliance of 6 medical groups, and our sites are located in eastern and central Massachusetts. We've been managing capitation in various forms for about 30 years, and we have all the typical attributes of an ACO and fairly comfortable in managing risk. VNA Care Network and Hospice is a long-standing VNA in Massachusetts, has been first in a number of areas, owns 3 hospice facilities. And one of the things that was most important to us is its geographical reach is sort of matches very nicely our geographical distribution. And so what this allowed us to do in coming together for all these reasons was really to have 2 entities, a physician's practice and a VNA coming together that covered the same area, that we could plan things on a kind of one point of contact basis and be financially aligned to manage a very large risk population. And so I want to talk about really kind of where those interfaces have been developed over the last couple years. 4 areas of focus. One is around improved communication. I'm a primary care provider. I practice a couple half days a week. I have a very elderly population. And I have for many years seen the disconnect in communication between the home care providers and the office practice. And so I know how important this is, as well as the teamwork and kind of how you would do program design collectively as opposed to separately in silos. And then metrics as an ACO, that's A for accountability. So starting with communication, we did a number of things, and in no particular order here. One thing is, visiting nurses, they do fall risk assessment, medication review, depression screening. That's kind of part of the usual intake. It ends up in one of those long computerized intake forms that the doctor signs, but may not get really incorporated into the record. So what we did was to ensure that on a daily basis, these assessments appear in our record in a very obvious place of when the doctor goes into the record to be able to see that they were done and what the results are. We also email on a weekly basis what's happening to each of the patients, and that's distributed to the care managers at each site who distributed to the physicians. We've encrypted email across all the organizations so that we can communicate clinically in a HIPAA fashion. We've instituted a automatic or automated referral system through our electronic medical record so that when a referral is made, it electronically goes to the intake person at the VNA. who has access to our EMR and has the full range of the medical information to set up the case for the VNA. Our VNA's information system is end of life, and we're looking at, because we too have Epic across all of our sites, we're looking at using the Epic home care module in the next year or two to fully integrate along those lines. And my hope as a primary care provider is to be able to automate the face-to-face and the 485 so that I don't have to come in to my office twice a week through a stack of perhaps 20 or 25 of these to sign. The second area of focus is around teamwork. Starts at the top. We put together a senior steering committee that oversees the development of our relationship. But of course, the real work is in the primary care practice, where we've integrated members of the patient-centered team with the VNA staff at various places in the continuum of care to be able to work together more collectively as a team. So one area we've spent a lot of time is in palliative care and end of life. We've done a lot of education around that. Here's some particular initiatives I just want to kind of review. One is geriatric roster reviews. These are team meetings in the doctor's office with the medical team, and we've now incorporated the VNA, and these are patients who have been identified as high risk, and there's a case review, and these what we call geriatric roster reviews are done pretty regularly at all of our sites. So this is one way we can incorporate the VNA into our program. We've done program design around all these areas, and I think a lot of this we've heard about today. So with respect to advanced care planning, VNA has developed a palliative care consult team that can work with the PCP and the VNA to manage those patients. And we've spent a lot of time looking at earlier enrollment in hospice. Massachusetts has the dubious distinction of being the high-cost state in the nation, and along with that, one of the lowest lengths of stay for hospice. So there's been a lot of low-hanging fruit there. We've developed a one-time visit home assessment. This is paid for not through Medicare, but through the groups. And I think one of the earlier speakers talked about this kind of program where you send out for a home assessment to answer very specific questions that you just need some eyes on the ground. We've developed a total joint program, and I know that a lot of organizations have done that. But I think what this is required is paying for, again, not through Medicare or through commercial payers, but through the groups, paying for certain elements that in return result in a much higher number of patients going home for rehab rather than SNFs. With the 3-day waiver that we were granted through CMMI for Pioneer, we've incorporated the VNA because why would we want to send a patient to a SNF from the emergency room if we can coordinate and care for that patient being sent back home with VNA support? These are some of the newer initiatives we're working on, expanding telehealth on a in-house payment model for CHF, and we're now starting a project looking at e-visits with video and diagnostic technology, and the home-based primary care program, which we're expanding. Lastly, in terms of metrics, I think in this age of value and accountability, we always have to have metrics that we're tracking. And so we've developed internally metrics to hold each other accountable and certainly the VNA accountable for how their performance is running. And we track these with, this is sort of one subset of our dashboard that senior steering committee views every month. Last couple slides, in terms of future directions, I think we're thinking of developing an internal bundle payment system. We looked at the CMI initiative, and it seemed very complex. And as you know, CMS puts a lot of strings on, and we think we have enough volume internally to do this. And we've started to work on that. One of the interesting, we have a very large clinical pharmacy program in our sites, and we're expanding this to have the clinical pharmacists support the VNAs at home around med reconciliation. Lastly, I would say, I think one of our major challenges has really been bridging that communication between the doctor's office and the home, and how do we do that better? And that's what all this work, the program design, the teamwork, and the communication has been about. And I guess that's it. Thank you.